especially with the coming changes, all the hospitals will be semi-private or private. So we will continue receiving the results and the studies from abroad, unfortunately.
Thank you. I think we go to the speaker. It's my pleasure to present my godfather in bariatric surgery, and I think he's the godfather for most of us, not all of us. I like to present to Dr. Ichihari. He's talking to give us an input about his experience in bariatric preparing and presenting care properly. Thank you.
الفيديو الأول
Sorry for change, Dr. Walid Bukhari is having an urgent issue, so we'll make a change in the
الفيديو الأول
drone
لا
out.
مو
He
الفيديو
will not continue with us, he will be
ايوه هذه prevention strategy ايش اللي تحتها؟ لا ايوه لا 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 preventive strategy for girls after LSG هو preventive strategy شوف الكتاب اعرف اقراه ثلاث حالات الكورونا والهيبس سويت حالة basically عندها severe fluctuation لازم نعمل لها نسن ماشي لا السجل كلوب هي ما نقدر نكبر الثلاثة فما يبقى هي لأنه لما تروح اللي هو على أساس الزوم دقيقة بس تقدر تقرأ من على هذه أقلب لك إياها بوينتر معه إذا بوينتر للأسف ما Preventive strategy for reflux after surgery. Reflux after laparoscopic sleeve gastrectomy and revision procedure can pose a challenge for all of us. We know that we're facing that in our practice. And it's crucial to implement effective preventive strategies to manage and minimize the risk of reflux post-surgery. And that involves so many aspects: lifestyle modification to dietary recommendations and medical interventions, and that forms a comprehensive approach, and that is required for the successful prevention. In this detailed presentation, we will explore various preventive strategies to address reflux after surgery, emphasizing the importance of early identification, patient's education, and personalized care. Understanding the changes in risk factors, post-surgery changes, understanding the anatomical and physiological changes post-surgery that contribute to reflux is crucial. And Professor Degel have explained part of that. Changes in the gastrointestinal tract and stomach capacity can directly impact reflux and reflux symptomatology. The risk factors, there are a lot, including diet, lifestyle, medical history, and that all can increase the incidence of reflux after surgery. It's essential to identify and address these risk factors proactively. Understanding the pathophysiology, post-surgery changes. First of all, the hiatus hernia. Several authors have emphasized, and I'm not going to dwell on that, my colleague have already mentioned that, but several authors have emphasized the importance of careful identification of hiatus hernia and repair to reduce incidence of post-arthritis, reflux, esophagitis, and esophagitis. And that also compromises the presentation of the patient. So we've seen a lot of centers that do not take that in consideration prior to surgery. In the latest consensus of the EFSO in Napoli, they emphasize the importance of having to do a preoperative fluoroscopy in symptomatic patients, even going up to as a routine upper GI endoscopy, pH-metry, and manometry, to be able to really give the a proper indication for those patients. Which surgical approach should we take? The panelists in the International Sleeve Gastrectomy Expert Panel concluded that aggressive intraoperative identification of hiatus hernia is a must. So a lot of surgeons would go and dissect and do the typical sleeve with a patient who have had no endoscopic positive outcome, but he did not do a pH-metry, did not do a manometry, depending only on the symptomatology of the patient. Those patients the hiatus must be explored. In the fat patients, you have what's called a fat pillow or a fat pad that fills up the space there, especially in supermorbid obese patients or highly morbid obese patients. So that must be explored, that must be dissected out, and the exposure of a wide crust has to be repaired through a cruroplasty. And they agreed that the hiatus hernia should always be repaired if found during performance of sleeve gastrectomy. Yeah, we go further. Intragastric pressure. Basal pressure in the sleeve was similar to the stomach, but pressures were significantly higher on occlusion and filling with saline. So when you get the stomach out and you try to fill it up with saline, the pressure in the gastric at that time is much higher than normal stomach, implying much lesser distentability of the sleeve. Higher pressure and lesser distentability will have an adverse impact on symptoms of GERD. Gastric emptying. Delayed gastric emptying is associated with GERD. Alterations in gastric emptying after SG could be potentially important in determining its effect on GERD. And as my colleague have mentioned, there is not much information and not much investigation have been given toward that direction. Lower esophageal sphincter pressure, and that is very important. The tone is an important anti-reflux mechanism. Alterations in lower esophageal pressure following sleeve gastrectomy must hence have some impact on incidence and prevalence of GERD. The increase in lower field sphincter pressure was dependent on the position of the stapler, closer to the angle of his or further away from, but not transecting the sling fiber. And we know that anatomically, it's not a true circular sphincter. There is sling fibers of the lower field sphincter. Mild gastric narrowing, the twisting of the stomach. Very important is to have a symmetrical cutting of the anterior wall and the posterior wall. The mildest of twisting or a narrowing on the way, so an uneven curvature. If you're going to do a sleeve on 36 French bougie, it's fine, or 38 or 40, but might it be a straight cutting symmetrical on both sides? For any narrowing in the stomach, we have seen that it increases the significance of GERD. Proximal gastric migration, that is very important. The migration increases the regurgitation symptoms and hence the GERD. طبعا lifestyle modification for prevention, dietary habits and physical activities. A lot of people have different dietary habits. Me, as a post-sleep patient, 14 years now, I know that I cannot eat certain foods, and they will aggravate my food severely. Sometimes if I smell it, مثلا salsa على spaghetti, هذه got like. Physical activity, definitely regular exercise, preventing yourself from eating 4 hours prior or drinking prior to sleeping, avoiding any fatty, sugary or complex carbs, foods at night is very important to minimize the bouts of reflux. طبعا avoiding this is what we mentioned. The next, early identification and diagnosis. Recognizing the symptoms is very important, and it's pivotal to be able to deal with it. And this includes heartburn, regurgitation, chest pain, difficulty in swallowing. And the diagnostic tool, everybody knows, endoscopy, pH monitoring, imaging, barium meals, and pH metry and manometry even further down the line. Surgical intervention for severe reflux, laparoscopic sleeve gastropexy with chloroplasty, state of the art. If done initially correctly, it will prevent the need of any further revisional surgeries, in my opinion. Laparoscopic chloroplasty and gastropexy, step 1, post-lap sleeve gastrectomy with success rate of above 88%. Still, we have a 12% in our work we have seen. We have 12% of, after we have taken those measures, we still see the reflux happening. And those patients, we might need to go further down to the well-known acceptable methods of doing Roux-en-Y bypass. Laparoscopic convergent Roux-en-Y gastric bypass, okay. Sleeve state-of-the-art protocol for performing state-of-the-art sleeve gastrectomy as follows. Using 3-port, this is what I do. Not necessarily you should do that. Some people can need 5 ports, 7 ports. It's no problem. Ports is no. But I am trained to do the procedure because I retract. I can measure the retraction. I can measure, and I don't have the fear of a young assistant tearing up a vessel or stomach. And this is, it's important, as we said, to always dwell in getting to the true hiatus. Sometimes it is not easy, but in my opinion, it's mandatory to be able to do that. And this is one of the old cases. that we use. That's the pharyngogastric ligament. We try to preserve it. As you notice, this is the straight bipolar that we were using. So this is probably more than 10 years ago. I try to cut make the antrum as small as I could without interfering with the without causing the narrowing of the stomach, and trying to be as symmetrical as possible, having an equal anterior and posterior gastric wall. I used to leave a big dog ear. Not anymore since more than 12 years. Now, this is the ligament I'm talking about. And that is a very strong ligament. Practically, you can take a stitch and hold the patient from the top of the tail. And this carries a dual function. You try to, first of all, minimize even the possibilities of post-operative bleeding, and fixating the stomach with the 2-3 centimeter of the esophagus in the intra-abdominal hollow, which we have agreed before that definitely plays a role in the occurrence of the post gastric sleeve reflux. And you can see that we used to take the omentum as a way to minimize the bleeding. We thought to minimize the leak, and when you move your bougie, you see the stomach would go up with you. With this type of procedure, stomach is in place with this fixation to the this ligament. Surgical intervention for severe reflux, laparoscopic chloroplasty and gastropexy. This is, I just wanted to show, as my dear colleague have just mentioned, that the migration of the stomach in the thorax is catastrophic. This patient's BMI was 14. And she was, for more than 1 year in and outside the emergency room for dehydration and electrolyte imbalance. And you see that the twist in the stomach played a major role in that. You see that the unequal cutting of the anterior and posterior wall plays a role in that. After we have managed to release more than 1/3 to half of the stomach from the thorax and bringing down the esophagus in the intra-abdominal hollow, it was easier to pass the bougie. And now this comes a touch of art, where you try to modulate the inequality in both walls. And this is again fixing it to this ligament. This patient is doing well for more than 10 years. Surgical intervention for severe reflux, laparoscopic conversion through NY bypass.
اشتغل.
again dissecting the hiatus. You have two approaches, either from the lateral side or the medial side, and either one that's your preferred is acceptable. What you find easier, more accessible. Releasing all adhesions to be able to bring a chronically migrating part of the stomach and thorax is very important. So that has to come down in the abdomen with ease. So all the adhesions, all the fibrous tissues, all the connective tissue has to be released. We saw how we repaired from the lateral side. Now this is repair from the medial side. And we take interrupted stitches, you take figure of 8 stitches, you take U stitches. Not important. Important is to get the belly and the bulk of the muscle. And you see that there's at least 3 centimeters of the esophagus retracted. You can see that it is in the abdomen. That was in the thorax or in the mediastinum.
Who is it this now?
Yes, absolutely, all the time. I like to leave the distance between the upper stitch, that's between the esophagus and the muscle, to leave a space with a 40 French bougie at least. Or usually, if you don't have that, 50-50. So the esophagus occupies 50% of the space to the last stitch.
It's the stomach. Do you use absorbable or non-absorbable?
In muscle repair, you will use braided polyethylene.
No down.
Where?
It's the stomach itself.
Yeah, no, I use absorbable, usually. But in patients who come without repair, with just great momentum, I use propylene, and I use because most of the time they need to have some sort of gastro سموها كشكش في المعدة بس like this is opening the curtain.
Especially if there is a boss sleep with care, this patient.
Yeah.
With boss sleep
Post sleep.
with care. Now, then
Severe care.
Did you recommend a mini bypass?
No, mini bypass usually would they have a higher percent of resulting reflex. Still, it's not the best choice. They're talking now about SADI with a wider stomach, patients, they say preservation of the pylorus and helping to do the bypass post-pyloric lesion. There is papers that are coming out soon.
Did you close the did you close the hiatus even كيف حالك؟
جوالك حلو.
Do you close the hiatus even if it's like a tiny small one, like less than 2 centimeters?
I will always, if there is,
If you do bypass it,
if I do a bypass, I will always
close it.
it's a chance that will not come back. And if that is the only element, if it's 10% chance, you're solving the problem. طيب, post operative care and follow up. طبعا check up visits very important. Is in the first year you see your patient 3 times, second year and third year 2 times, and fourth and fifth year once, and then after that whenever it's necessary. Conclusion and key takeaways: individual care, personalized approach to reflux prevention, considering each patient is a unique element and needs medical history, detailed medical history. It is vital to recognize and diagnose patient. Continuous monitoring, establishing long-term monitoring and support system is essential to sustain reflux prevention post-surgery. Okay. Thank you.
Discussion, you have any question, potatoes?
Question. I think if we take it, hopefully, at the end of the day, we'll not be satisfied.
Wallahi, I have an emergency. I have to go. I apologize. يعني جيتكم من العمليات. I made it a point to be here. شكرا لكم. يا معلم شكرا.
كمان معنا؟
تليفون يرد.
الله يعطيك الصحة. يا أهلا وسهلا يا ولد. طيب احنا will continue. They will introduce the next speaker. كان المفروض ناخذ كذا 5-minute break، لكن عموما the coffee break is there. You can go individual واحد. I'll take your coffee and come back. تفضل.
It gives me a great pleasure actually to be here first of all, and to introduce a friend, a colleague, and a very experienced gastroenterologist, Dr. Imad Al-Chahdari. That he's well known to, if not all, most of us. He's walking with his own into the landscape to give us a talk today about the medical and preliminary options in treating GERD patient post-sleep gastrectomies. Very briefly about Imad. I knew Imad for the last 10 years plus now, and we work together in the university. He's associate professor of gastroenterology. He's the head of our GI oncology unit as well as the advanced. Very briefly about Imad. I was Imad for the last 10 years, so without further ado, we're really happy to have you, Imad. And the university is
Allah يعطيكم العافية. Thank you so much for actually hosting me into this great event. And this is the first time I meet in person with most of those who call me for like few things. يعني ما شاء الله تبارك الله, you're a completely full-fledged independent surgeon. لحد فترة من الفترات I thought myself, like I consider you as big guys when I'm the mafia doctor. Do you know the mafia doctor? When the mafia comes in injured and you suture him and he goes back to the streets. But every one of you is like a legend in his field. But at the same time, we as growing in medicine and more devices coming out, more challenges, better understanding of the problems we're facing, we come to the point that multidisciplinary approach actually is very healthy relationship in any institute. يعني الحارس المرمى له أهمية زي الدفاع زي الهجوم زي باقي الفريق كله. Once you have that kind of team, when you have a gastroenterologist and preventionist who can actually sort out and certify the patients, help you to make the better decisions for you and for the patient, that's where we come in as a team. طبعا I was assigned to give the medical management of GERD after bariatric surgery and endoluminal therapeutic options. للأمانة it's a very intense topic. It starts with زي دكتور صالح ما تفضل Professor صالح إنه it starts even before you do the procedure, not just after the procedure, being proactive, not reactive. So I'm not just going to spend much time about GERD itself because most of us know this, but I'm going to focus on it's actually GERD, the prevalence of GERD within our area, the GCC area, Middle East, is higher than anywhere else for many factors, including weight as the first place. But specifically in the bariatric patients, the obese patients, it's even much more higher, meaning that for a normal individual, obese patient has twice to 2.5 higher risk of developing GERD. And that's what comes as one of the indications maybe to help them lose weight to get rid of the symptoms. But again, focusing on the prevalence again, it's not related only to BMI. So even you could have not a high BMI, but the visceral obesity or central obesity can result in you having symptoms regardless of your BMI. So that's where we have to make sure that we are looking at the patient not as a number, but as a whole. Now, coming back to the relationship between bariatric procedures and GERD, it can actually go both ways. It can either help the patient getting rid of the GERD symptoms based on losing weight and visceral obesity or central obesity. But on the other hand, as Dr. Waleed mentioned, and Dr. Saleh, the sleeve itself or the procedure itself or the kind of procedure we're performing actually can result in either the initiation of GERD symptoms or worsening of the GERD symptoms. And that's come as some of the studies actually may tell you that that kind of procedure, specifically sleeve, is contraindicated in this patient because they have large hiatal hernia. So think about something else. Now, this study, basically looking at the the GERD, obesity, and laparoscopic sleeve gastrectomy, the burning questions, we're looking at 3 specific questions about the prevalence of GERD, erosive esophagitis, and that kind of population, the preoperative endoscopy and the need for that, and also looking at the long-term effects on GERD when you do sleeve. And that actually concluded answering the first question. GERD has been reported about 62 to 70% of the patients going for bariatric surgery, and mainly because of the 4 factors: the increased intra-abdominal pressure, the effect of the adipose tissue or central obesity in loosening or weakening the lower esophageal sphincter, which we can call as decreased lower esophageal sphincter, impaired gastric emptying, as Dr. Waleed mentioned, and higher frequency of or prolongation of the transient lower esophageal sphincter relaxation. All of these things can lead to GERD. Now, clinical practice guidelines in the American Association of Clinical Endocrinology, the Obesity Society, they kind of recommending doing preoperative endoscopy when it's indicated. If you feel like the patient have the GERD symptoms, if you want to rule out or to document the size of the hiatal hernia or rule out the presence of erosive esophagitis, do pre-endoscopic evaluation. The American Society and their guidelines in 2015 recommended decision to be individualized. European Society, all of them should have pre-endoscopic evaluation or endoscopic evaluation. But the overall, I am one of those, as some of the surgeons may recommend doing preoperative or pre-bariatric endoscopy for other reasons, not just for GERD or reflux, maybe for just or mural masses or big ulcerations or whatever reason. So we may have more than one indication to do the scope, but it can be very helpful. Now, the kind of relationship has been subject to interest. Bariatric operations have been reported to both cause and cure GERD, as we mentioned. Now, this study actually looking at, they conducted a systematic review and meta-analysis revealing that bariatric surgery can alter the natural course of GERD. This is specifically looking at, is bariatric procedure, including gastric bypass and sleeve, would change and alter the esophageal motility? Is that actually a real relationship between the two? And actually, some studies have found that those patients ongoing for sleeve, they actually have an increased risk of adenocarcinoma, which may be related to Barrett's, which may be actually the cause of GERD to start with. So I was having that discussion with Dr. Saleh. Should we do all procedures going, all patients going for bariatric manometry like we do for anti-reflux procedures? That's a question and a relationship that has to be established. Now, furthermore, that study actually emphasizes the importance of preoperative assessment of esophageal motility in bariatric patients to identify potential postoperative complications in silent disease. Now, moving to the management. So that was actually about the preoperative workup. Moving to the management. Once the patient presents to me with post-sleeve GERD symptoms or worsening symptoms, what should I do? The common things: lifestyle modification, lose some weight if you could, smoking cessation. If you're a drinker, stop drinking, avoid fatty, fried food, meals, whatever, exercise. But unfortunately, this doesn't work all the time. And those patients can be dependent on PPIs, high dose, which can lead to osteoporosis. So actually moving away from the obesity complications to the risk of having fractures, kidney disease, cardiac situations, increased risk of C. diff infections. Those patients can present with altered bowel motions. So we are still in that limbo of how can we get the patient in a better life style. Now, I'm going to move to the surgical options that you have mentioned, and then move to the endoscopic options that we can offer as an endoscopist. So if I have a patient with gastric sleeve who comes to me with reflux, especially if they still are not satisfied about their weight, it's an easy answer. Go to bypass. You could lose weight, could actually minimize the symptoms or eliminate the GERD. However, resolution of GERD after that kind of surgery was reported about 65%, but 22% are still symptomatic and profoundly symptomatic. So they don't improve. So that's not the magical solution for those patients. Now, Dr. Ashraf and you guys have a better understanding of these. I'm getting list. You can reduce the gastric pouch. In that case, you can revise the anastomosis, especially if there was a large pouch or marginal ulcers. You can actually lengthen the rule limb in cases with bile reflux. You can also do other surgical options such as fundoplication, using the gastric remnant, Belzy bark, sphincter augmentation using links, as my colleague Dr. Ashraf was doing at our institute. Now, how about the endoscopic options? In a normal anatomy, we have a patient that never had surgical resections, maintaining his normal stomach. We can offer them the endoscopic fundoplications. We can do either TIF using the esophagus or the Gerdix, which are very successful. By the way, TIF has longer history than esophagus, but both are actually very effective. We can use the thermal ablation procedure known as strata. It just makes the area of the sphincter very limited and fibrosed. Or we can actually do something called endoscopic suturing, especially if we have Roux-en-Y, gastrojejunal anastomosis, or we can do something called mucosal therapy, ARMA, which I'm going to talk about. So, I'm not going to spend much time. TIF is well known. The magic move about TIF, it does do the fundoplication, but at the same time, it elongates the high pressure zone, which is about 1 centimeter. In those patients, we can extend them to 3 centimeters, 4 centimeters, and can be very effective. Gerdix almost does the same thing, but it just make the area narrower, but it doesn't elongate the sphincter. Strata, thermal ablation. It's one session procedure, takes about 15 minutes, maybe half an hour. The patient would walk out of your unit for 6 months or free of symptoms. But once the edema effect of that ablation resolves, patients most of the time have recurrent symptoms. So that's why we don't find them in the guidelines, where in Europe or in the States, it has a very limited recommendation. Now, this actually study has looked into that, which was very supportive of doing strata on patients after sleeve on Roux-en-Y gastrectomy, but those patients actually did not have lasting effect, and that was done in 2000. 5 or 15. This is a much more recent study, was done a few years ago, recommending that only 6.7% of those patients can have long-lasting effect of stratum. Now, how about the anterior flux mucosal ablation, which we call ARMA? This, just of note, has been recently established. It's done much in Japan and the States, but at our center, we have started doing them for the last year. I've done so far about 10 patients, and I'm just going to explain the procedure quickly here. Sorry. So basically, this is a patient who underwent sleep. If you can dim the lights, maybe you can see better. Oh. Okay, whatever. But, so basically, I determined the presence, the Z line itself. The Z line is located maybe 35. There was a small hilar hernia, and this is actually the retroflex view inside the sleeve. Once I determined the area of interest, so the sleeve has a mark where actually do the incision. So I avoid doing that. I'm going to forward the video, so I'm not going to spend much time. This is the area with a small sleeve. This is Hill grade 3, small hilar hernia. So once I mark, I do the submucosal injection to push the mucosa away from the deeper muscles, because that thermal therapy can do transmural damage, which can be very painful to the patient. So once I mark the site, I choose my target, you can see how wide is this. This is actually a patient with a gastric bypass, by the way, sorry. So once I mark that, I start doing the ablation using the RFA. She had sleep, then converted to gastric bypass and still had symptoms. So under thermal ablation, I ablate the cardia itself completely, try to completely destroy the tissue, forming a scar, which will result in a 360-degree narrowing and decrease the symptoms eventually. So the end result of this is like that, almost like this. I do some of the distal esophagus. Right, so that's the end results basically. So if you ask me about what's my initial impression about this procedure, now I have done almost 10. 6 of them reached a 12 months mark. 60% of their symptoms improved. Some of which actually did not use any more Gaviscon with the 20 milligrams of nicotine. We used to do more than that. Some of them actually were able to go back to their lifestyle without worrying about eating in public or having nausea and vomiting. So this is a very promising, again, in those with a surgically altered anatomy of the stomach, because we cannot provide any fundoplication endoscopic. Maybe the patient refuses to go under Roux-en-Y or gastric bypass because of feeding, having complications, or they actually reach the weight, and doing Roux-en-Y can actually make them lose more weight. So this is a very effective procedure, which we call ARMA, and it has a very good potential. And that's the end of my presentation.
Thank you very much.
You're welcome.
Very interesting thing. From the thing of routine of endoscopy, but sometimes the crowd is overcrowded with our colleague in gastro. We cannot do it as a routine, but as indicated. Next speaker will be our colleague, Dr. Ali Bakari.
We'd like just one question to ask.
One,
All of them.
that's thanks for the time, but
We forgot. The previous speaker, you ask us to ask a question. We will continue the same or not?
لأنه هو آخر محاضرة وبعد كده ناخذ ديسكشن وبعد كده ناخذ العشاء بعدين الساعة 10. Go ahead, Dr. Hamid.
Yes, just one question, Doctor. like thermal energy, which is cause fibrosis in this area.
Yes.
How is the dysphagia of the patient?
Never happens because
Why?
Because basically when you do that, you do it under widely patent lower esophageal sphincter, smaller hernia. The best you could hope for is minimize that opening, but it will never get to the point that it closes.
It doesn't allow the acidity to.
So the whole point, the cardia itself, when it's exposed to that kind of mucosal injury, the stricture ring that will form will decrease the opening to some extent. But at the same time, it reduces the hernia length. I see. Which will bring the esophageal sphincter to a lower level closer to the diaphragm. That's at least the hypothesis behind it. So the more thermal energy you apply, actually, the more fibrosis you make, the scar tissue will bring the stomach, the opening itself to a smaller diameter and to a shorter length away from the diaphragm. Patients, most of the time, they will have less symptoms, but not completely disappearing symptoms. Like for this patient, instead of using 40 milligrams of Nexium twice daily on top of Gaviscon, she stopped using Gaviscon. She's only using 20 milligrams of Nexium and she's happy, which is very helpful. She hasn't been able to do this for the last 6 years.
Thank you.
Just because of matter of running time, أنا آسف. بس طيب next speaker Dr. Ali Bahrawi, he's a consultant of Batayyah bariatric, head of bariatric unit in King Abdullah Medical City. Welcome, Dr. Ali.
Right. Thank you very much. First, I would like to thank Dr. Assam, Dr. Ali Montasheri. Honestly, the speakers made my job very difficult, so I will try to go quickly through my presentation. This is the outline. I'm going to talk about how sleep might reduce actually GERD and the evidence behind it, and how sleep might induce de novo or even worsening GERD, the incidence of GERD after sleep, the surgical strategies and techniques that we can do during sleep to minimize the incidence of GERD, the intrathoracic sleep migration, barriers in sleep, some consensus statements from IFSO, from SSMBS, from some important meetings, and surgical management of refractory GERD after sleep. And if I have time, we have a small study we did at KMC that I would like to share with you. So first, GERD and sleep, that honestly, it's very complex, very controversial, multifactorial. There is too much evidence that GERD get worse after sleep, but there's still few evidence that it might get better. It's even in the literature, it has been reported between 5% to 50%, so there's large discrepancy. Patient with GERD had sleep gastrectomy will get even worse GERD when we compare it to Roux-en-Y gastric bypass. Presence of GERD for some surgeons is a contraindication to sleep gastrectomy, and Barrett's is even an absolute contraindication. So what is the mechanism that sleep might reduce GERD? First, by reduction of abdominal pressure due to the weight loss, by resection of the acid-producing fundus, so we have less acid in the stomach. Reduced gastric volume, it's a little bit questionable, and accelerated gastric emptying. There are some studies showing that the patient who had sleep, they will have an accelerated gastric emptying, and other studies reported delayed gastric emptying. This is some literature. If you can see, this is like from 2012, so it's almost more than 1 decade. The debate started more than 2 decades and still ongoing. This is a prospective study done on 37 patients with who had a preoperative lower esophageal sphincter insufficiency. They did manometry. They did like 20-point hold. They did manometry just the day of surgery after sleep gastrectomy, just after the healing, and then 6 months later with whenever the patient had significant weight loss, and their results was the sleep gastrectomy significantly increased the lower esophageal pressure, independent of weight loss. So just after the sleep, they measured the lower esophageal sphincter pressure, and they compared to pre-op, it was higher. And then they do it like 6 months later, it was even higher. So it's a little bit controversial because I'm going to show another study which contradicting this study. And it was done prospectively on 37 patients. That's a systematic review, which was also published 10 years back in 2013 and included, like the title was Sleeve Gastrectomy and GERD, a complex relationship. So they did like a systematic review and meta-analysis of all studies which showing that the sleeve might reduce the GERD, and those are the studies. The issue with those studies that most of them, the evaluation of GERD was done on symptoms. Like only maybe 1 or 2 studies, there was EGD or manometry or pH metry. And that's the same systematic review that Prof. Duggal just mentioned earlier, which was published in 2022. And as he mentioned, still in like recently, there is a controversy about sleeve gastrectomy and GERD and whether there is de novo GERD after a sleeve or not. And with this data, the most recent study have shown satisfactory control of post-operative reflux in most patients and low rates of de novo GERD. This data are leading to wider acceptance of a sleeve as a bariatric procedure in patients with GERD, which is questionable or debatable. So why sleeve might induce de novo GERD or might worsen the GERD? So there are many theories. Prof. Walid, like mentioned, most of them decrease gastric emptying by removal the gastric pacemaker and decreased antral pump. This motility due to the decreased plasma ghrelin, decreased compliance of the stomach, and it happens early, maybe later on, the stomach widen up and it will have more compliance, reduce lower esophageal sphincter pressure and blunting the angle of His, increase intragastric pressure secondary to a narrow stomach, and herniation or intrathoracic migration of the sleeve. So this is the muscle fibers that Prof. Walid just mentioned earlier. There is no like anatomical lower esophageal sphincter. It's made mainly of muscle fibers. We have the clasp muscle fibers, which are looping muscle fibers, and we have also the sling muscle fibers, which are like oblique or longitudinal muscle fibers, starting from the angle of His. So while we're doing sleeve, if we go really close to the angle of His, we're disrupting some of the same muscle fibers, then we are disrupting the function of the lower esophageal sphincter. So most of the recommendations that we go a little bit away from the angle of His, maybe like 1 centimeter away from the angle of His when doing the last fire. And this is a study, they did a manometric measurement of the lower esophageal sphincter. It's completely contradicting the other study that I showed earlier. They did it on 20 patients and it showed like 6 months after surgery, that sleeve gastrectomy produces an important decrease in the lower esophageal sphincter pressure, which can in turn cause reflux. This is another study. They did a pH metry, and also in conclusion, they found 3 months after sleeve gastrectomy, there was a significant increase in esophageal acidity. And this is the same study I mentioned earlier in 2013 about the systematic review in sleeve gastrectomy and gastroesophageal reflux, a complex relationship. And those are the studies that said that like sleeve cause more reflux. So when we talk about the prevalence, it's hard to get it. So this is a retrospective study which was done on more than 1,500 patients, and they did endoscopy for all those patients, and they found up to 25% of the patient post-sleeve gastrectomy from 2 years to 5 years, they have some kind of esophagitis, grade B and above. 20% of those patients required a surgical therapy for their GERD, and the conclusion, medical treatment should be first. If failed, we have to convert to another surgical procedure. The most common is laparoscopic Roux-en-Y gastric bypass. If we talk about that, what are the strategies that we can do during our sleeve gastrectomy that can minimize the GERD after the surgery? First would be the coronary repair, and it's very important whenever we find a hiatal hernia that we go ahead and fix a hiatal hernia. We should be very meticulous for digging for hiatal hernia and try to fix it. Gastropexy, the Nissen sleeve by Dr. David Nocca, ligamentum teres cardiopexy, and antral preservation. So this is I think there's a consensus between all surgeons now. Whenever we find a hiatal hernia during a sleeve gastrectomy, whether preoperative or intraoperative, we have to go ahead and fix it. So that was a study by Sorcelli from Italy. He studied 400 patients who had sleeve gastrectomy. 1/4 of those patients he did a concurrent sleeve gastrectomy with crura repairs. So he took a couple of stitches at the crura. Like his results, he said there was significant high rates of de novo GERD in patients who didn't have crural repair, 23% versus none in the patient who had crural repair. So he was advocating for crural repair for patients with sleeve gastrectomy. And this is the Nissen sleeve by Dr. David Nopka. He leaves part of the fundus and then he do like a 360 wrap. And that's a result of 70 patients of his cohort. He shows we have the mark, we have the pointer. So actually they show that the pre-op GERD was 50%, post-op GERD is almost negligible, 1%, patient who had asymptomatic GERD, 15%, and post-op 1%. It's too good to be true, honestly, but that's the result that he reported. And that's another systematic review of all the patients reported on the literature about the Nissen sleeve. For 18 patients with GERD, they had the Nissen sleeve. Post-op GERD was 4.8%, and there was percent of excess weight loss was comparable to the normal sleeve. Leak was a little bit higher, 2%. The conclusion was fundoplication sleeve gastrectomy has promising early outcomes. Another study that David Nopka he published about doing the end sleeve, the Nissen sleeve for patients who had Barrett esophagus. They did sleeve the Nissen sleeve for them, and their results also are very promising. He said 54 patients had Barrett esophagus before the Nissen sleeve. At 2 years, he did 38 endoscopy, and it was healed in 25 out of the 38 patients, which is 64%. Another 3 years later, he did the endoscopy, and more patients, 5 or 7 patients who had still the Barrett's completely healed. So his conclusion, the Nissen sleeve has favorable outcome on development and regression of Barrett esophagus with sleeve gastrectomy. So what about the ligamentum teres? So they take the ligamentum teres and they just scrap it about around the upper part of the stomach doing a cardiopexy. That was a study which started in 2018. The aim was to recruit 30 patients and to see the result on GERD. But actually what they did, the follow-up was 30 months. The study was aborted after recruiting just 5 patients because of the dismal result of the study. So they had 75% recurrence of GERD symptoms at 12 and 24 months follow-up, and the study was stopped just after recruiting 5 patients. And we would recommend to consider other options in patients who might need endoscopic follow-up. One important mechanism that some literature showed that it might decrease the reflux is to increase the antrum from 2 to 6 centimeters. So to keep at least 6 centimeters of the antrum, so we have a good antral pump, and that's a study which shows that they compared 6 centimeters antrum to 2 centimeters antrum, that they had less complication, they had less vomiting, and they had less GERD in the first few months post-operatively. However, it was associated with less weight loss. So what about intrathoracic sleeve migration? The incidence of intrathoracic sleeve migration, that's a study which was a retrospective study in multi-center between 2013 and 2018, was 24 months follow-up. They did the endoscopy and they did upper GI imaging in those patients, and they found that the incidence of intrathoracic sleeve migration was 7%, which is high, 10% of the patients who had sleeve, and all of those patients didn't have hiatal hernia or required any choriplasty during the sleeve. Barrett's and esophagus. Barrett's and esophagus, this is an important paper published in 2017 by Jenko, in which he mentioned that he did endoscopy and biopsy for 110 patients undergoing sleeve gastrectomy up to 5 years, and they found the incidence of Barrett esophagus to be 17.2%, which is very high. I dig a little bit in more, and I found like a systematic review and a meta-analysis of all the paper which reported the Barrett's esophagus after sleep, and there's a huge variation in reporting Barrett's esophagus after sleep. This is a study which showed like in 110 patients, no Barrett's esophagus. Other study in 90 patients, they had 17 patients who had Barrett's esophagus with variable follow-up from 10 years to starting 18 months to 10 years. And I think in our practice, the instance of Barrett's esophagus here is very low. And what do you think? Do you see like Barrett's esophagus, or it's not that common? I think it's much more common in the West than reported here. Those are the few statements from the first international consensus conference on sleeve gastrectomy. So that was 50 bariatric surgeons, experts from 25 countries. They said like 92% of them agreed that EGD is mandatory before sleeve, and 80% that it's mandatory also after sleeve. There was no consensus on the time of EGD, when to do the EGD, and whether we should add other tests or no need for other tests. 94% agreed that high degree of erosive esophagitis, and 96 agreed that the considered Barrett's is a contraindication for sleeve gastrectomy. 84% recommended conversion to Roux-en-Y gastric bypass in uncontrolled GERD, and 78% in Barrett's. Hiatal hernia was agreed by everyone that it should be repaired. This is the consensus, the first modified Delphi consensus statement on sleeve gastrectomy. They had the 56 experts from all over the world. If you see the list, you're gonna know most of the names here. So that was the consensus. 90% agreed that surgeons should stay at least 1 centimeter away from the angle of this to avoid the string fibers. The precardial pad of fat should be routinely dissected, avoiding large posterior fundus. 98% agreed that when performing a sleeve gastrectomy, care must be taken to avoid leaving behind a large posterior fundus. 94% agreed that the merits and demerits of routine hiatal dissection to identify occult hernia need further examination. So there was no consensus yet whether we should go ahead and dissect the pad of fat and dig into the hiatus, try to chase a hiatal hernia. There was no consensus about it. 92 agreed that patients with pre-op or intraoperative diagnosed hiatal hernia should go under concomitant hiatal repair. Posterior repair is much better than anterior repair, agreed by 87%. The same group disagreed that the sleeve gastrectomy is an acceptable surgical option for patients with Barrett's esophagus, even if they commit that they're going to do an yearly, lifelong annual Barrett's surveillance. They also disagreed that sleeve gastrectomy should never be offered in patients who had erosive gastritis more than grade C, even if they commit to do an endoscopic surveillance. And for sure, that sleeve is not a good option for a patient having Barrett's, whether with dysphagia or no dysphagia. So what are the surgical management of GERD? For sure, Roux-en-Y gastric bypass is the most common option. This is a systematic review also about all the conversion from sleeve to Roux-en-Y gastric bypass from the MBS with data, 13,000 patients who had conversion from sleeve to bypass. The main reason, 50%, more than 55% was because of severe reflux. And the conclusion that they found that the Roux-en-Y gastric bypass, it has a higher rate of serious complications, yet it's safe with no mortality, and the cure rate of GERD was up to 70 to 80%. Can we use, you asked earlier if we can use one anesmosed gastric bypass. So actually, this is a study that compared one anesmosed gastric bypass versus Roux-en-Y gastric bypass as a revisional procedure for failed laparoscopic sleeve gastrectomy. The primary endpoint was for weight, but they also looked for GERD. So after conversion of one anastomosis gastric bypass, remission of GERD, the patient who had GERD and the risk remission was 68.6%, almost 70% of the patient who had GERD with the sleeve had mini gastric bypass, and they had a remission compared to 81% up to 186 patients who had the sleeve and then they were converted to Roux-en-Y gastric bypass, but there was no statistical significance. De novo GERD after conversion from sleeve to mini gastric bypass, there was 6.3% versus only 0.5%. So it's still a valid option. Maybe it's not the best option, but maybe it's a valid option. It depends on maybe the esophageal manometry, the lower esophageal sphincter. So another option, we have the expert here, Dr. Ashraf Marabi, links after sleeve gastrectomy. Some patients, we offered them, let's do a Roux-en-Y gastric bypass, and they said, no, we are happy with our weight loss. I don't want to have a bypass because of the complication of the bypass. I don't want to get internal hernia, marginal ulceration. Can you find me any other solution? So GERD, like links the magnetic beads or the magnetic lower esophageal magnetic beads. So this is, we just started to do them even at King Abdullah Medical City. We just started like one case, but we have a few cases in the pipeline. And this is like the links after the placement, and we see the bougie coming in, coming out, and whenever it comes in, it just opens the beads. And it's too early, I think, Dr. Ashraf. How many patients we performed so far after sleeve gastrectomy? 33, طيب, mashallah. And this is the study I found in the literature by Dr. Dina Khitan about, she presented 30 patients who had the links after sleeve gastrectomy, and the results are marvelous for the explantation or the need for removal of the device. 2 devices were removed. One because none had erosion, but just the patient had severe dysphagia. Regurgitation lowered in 61%. Patient satisfaction was 81%. Esophagitis was better in 54%. There was no erosion and 0 deaths. Conclusion in patients who had sleeve gastrectomy for obesity and who will still experience GERD symptoms, magnetic sphincter augmentation appears to be a safe and effective option with comparable morbidity to those who did not have sleeve gastrectomy. So that's the study that we performed at King Abdullah Medical City. So this is what we did. Like we had like many surgeons, but one surgeon, he did like sleeve and he does gastropexy and omentopexy for all the patients, and the rest of the surgeon, they don't do it. So we just compared, we did endoscopy for those patients at 2 years and 5 years post-surgery, and we gave them a GERD questionnaire. And we saw whether there was any difference in, I think they have the video, it's not right. So that's the technique. So I'm just, so this is Dr. Ali Monteshri. It's courtesy. So what he does here, he's doing some kind of cardiopexy. He's fixing the stomach to the left crust, to the omentum. And then he's running the whole omentum until the end of the stomach. So we compare those patients with patients who had sleeve gastrectomy without the additional omentopexy or gastropexy. Baseline, there was no any difference. We compared 210 patients, 195 patients, so everything was almost equal. We checked for potential confounder, for smoking, for patient taking any acid-lowering medication, and then we did the health-related GERD questionnaire, and there was no difference in both groups. Like patient who had gastropexy with omentopexy versus no gastropexy, omentopexy, 2 years to 5 years, they had no difference. Endoscopy also, there was no difference. Patients who are still dependent or still need to take PPI after sleeve gastrectomy was comparable in both groups, like almost the third of the patient is still complaining of GERD, either occasional GERD or they still need to take daily DPIs. Study, I have the result of the endoscopy, but still working on the statistical analysis. There was no difference. The study was neither prospective nor randomized. GERD symptoms occurred in both groups was equal, 30%. Adding gastropexy or mentopexy did not affect the incidence of GERD symptoms at least. So that's it. So to conclude, I think more unanswered questions that answer questions. Are there technical modifications during sleep gastrectomy that really provide better control of GERD? We don't know. Is GERD an absolute contraindication? Recent data showed that still patients might benefit from sleep gastrectomy even if they have GERD. Frequency and duration of GERD surveillance for sleep gastrectomy. When should we start? When should we stop? Best management of refractory GERD. For sure, we have to start medical, then endoscopic, like Dr. Ahmed Jahdari mentioned. Roux-en-Y gastric bypass, mini gastric bypass might play a role, and links. Thank you very much.
يا اخي انا اشكرك انك عملت الاستدي هذه. انا would love to see it بصراحه لانه عادي انا اشتغلت معاه بقى سنوات ثلاث سنوات كان معذبني بكاسر بيكس
Like I have
لا أنا honestly I just sent him the endoscopy results.
Yeah, this is change and the technique is completely changed from the video. The technique in the video not adopted until 2017. So we started doing phrenosophageal ligament reconstruction and fixation to gastrocolic ligament, the same way doing Dr. Bukhari. Most of the cases, including the study, I was doing just mentopexy. Just doing mentopexy as buttressing. So it's the mentopexy doesn't have any effect on the GERD. That's what we're looking for. It is the phrenosophageal reconstruction, which is I've seen on my patient like observation. I did not do any study. It's I have much less reflect from the previous experience with my patient.
You mean fixing it to the left cross?
Fixing, yeah, it's described in the literature. This technique, it's called phrenosophageal reconstruction, BLR. So you can look at the literature. There is Italian and French study about that. You reconstruct the phrenosophageal ligament. It's the left cross to the try to fix the left to the upper stable line. Idea is to fix the stomach, prevent migration, because the GIGO study showed like 80% of the cases that they have paresophagus, 80% they will have intragastric migration, sorry, intrathoracic migration. So that's one of the predisposing factor for GERD and birth development in most patients, which is the migration of the sleeve into the esophagus. But as I mentioned, we did not zero, we're not reaching to zero, but at least we have less gastric complication. We are doing triple fixation. It's not a fixation, it's triple attachment. We are doing phrenosophageal ligament attachment now, plus mentopexy, it's just buttressing, it's not having any benefit. And we are doing also the the pre-pancreatic fascia, it's mainly pre-pancreatic fascia. We're fixing into the stomach. I'm not sure it's for me, it's not time consuming. It's we get used to it. Me, I'm doing this. Dr. Rafa is not here, but Ashraf Marvid still doing the other degree. Okay, so this is we're doing it. It was time consuming in the beginning. Now it doesn't take more time than the usual. We feel free. We find most of the things that the gas will stand on the complete post surgery is less vomiting, less dysphagia, less like problem with eating. But as mentioned by Dr. Al-Bahrawi, it's need to have comparison arm. I think this is the best thing to have comparison arm. But the initial experience from 2013 to 2017, we're just doing mentopexy without any touch of the cardia.
I think, do you have any question for Doc?
It's amazing in many bypass.
Key literature, and I just mentioned one is systematic review, but few other studies showing, that was honestly the best. Other studies showing from 50 to 70%. The sleeve bypass of different literature, if you look at the literature, sleeve bypass post sleeve for reflux. أهم حاجة بس lower esophageal sphincter we have to do manometry make sure that the lower esophageal sphincter is not that weak. ولو عندهم hiatal hernia you should fix a hiatal hernia and you should do it as long out as possible. So you have to go really just next to the pylorus on the antrum and do the mini gastric bypass so you don't get like bile reflux with the acid reflux.
I agree with you, the most important to have this or stenosis previous. So we will go down, you will not solve the issue.
I spoke to Dr. Rohit himself and his group, which is the Indian guy, I forget his name. Kora, or that's it is within me. Kola, yeah, I met him and now we have to differentiate between GERD in primary MGB and GERD in post revision. In primary